السلام عليكم ورحمة الله وبركاته. راح نكمل محاضرتنا الثانية حول موضوع Subfertility. You remember in the previous lecture we talked about the etiology of subfertility, and then we also talked about the evaluation of infertile couples. Started with the history, physical examination, and investigations. Now we reach the treatment of subfertility. This lecture is about the treatment of subfertility. First of all, there are many factors affecting the conception rate. Those factors are female age. Female age is a very important factor affecting female fertility, while more than 35 years old is liable for infertility than younger female. The duration of infertility, more than 3 years. Infertility affects the outcome of infertility adversely. Baseline cycle, day 3 FSH level. If cycle day 3 or 2 FSH level more than 10 international units per liter, it affects adversely the fertility outcome. Previous conception. If the female has primary infertility or secondary infertility. Primary infertility is worse than secondary infertility. Secondary infertility, that means the female has or had previous pregnancy, whether live birth or abortion. Lastly, sperm function. Severe male factor affect fertility reversely. First of all, we talk about the treatment of female infertility. The first cause of female infertility is ovarian or anovulation. So, treatment of anovulation. Remember from the previous lecture, we have 3 types of anovulation. WHO classified anovulation into 3 types. First 2 and 3. First class is hypogonadotrophic anovulation. Class 2 is normal gonadotrophic anovulation, and class 3, which is rare, is hypergonadotrophic anovulation. First drug or drug of choice in the treatment of anovulation is the Glomfin citrate or Clomid. What's the Clomid? Clomid is non-steroidal oral agent, has both estrogenic and anti-estrogenic properties. First synthesized in 1956 and used as ovulation induction in 1961. What's the mode of action of Glomfin citrate? Glomfin citrate first action is central in the hypothalamic receptor. This is central action of Glomfin citrate. A block estrogen receptor in the hypothalamus. So when these receptors are blocked, there will be no any more negative feedback of the estrogen on the hypothalamus. So there will be higher level of GnRH hormones from the hypothalamus secreted and will act on the pituitary gland and causes higher level of both FSH and LH secreted from the pituitary gland. So there will be higher gonadotrophin secretion from the pituitary gland, which acts on the ovary and cause folliculogenesis and ovulation. Second action of Glomfin citrate is direct action on the ovary. Direct stimulatory effect on the ovary itself. What are the indications of Clomid? First of all, is the treatment drug of choice in the treatment of class 2 WHO anovulation, which are normogonadotrophic anovulation. Most common type is polycystic ovary syndrome. Those patients have normal or near normal estrogen level. How we can detect those patients? By progesterone challenge test. What we mean by progesterone challenge test? We give progesterone drugs in the form of tablets, oral or injection. هاي نسميها الحبوب المنظمة. Either oral tablet or injections progesterone if the patient develop withdrawal bleeding, so that's mean the patient has a good level of endogenous estrogen in her blood. Adequate estrogen. This is WHO class 2, which is most commonly found in the polycystic ovary syndrome. Second indication is assisted reproduction technique, like in intrauterine insemination. Third, treatment for unexplained infertility. And the last, treatment of endometriosis to increase the quality of oocyte. No role of clomiphene citrate in hypogonadotrophic hypogonadism patients. Why? Because they already have no hypothalamic or no pituitary function, and the Clomid needs intact hypothalamic pituitary axis. Contraindication of clomiphene citrate. Pregnancy, chronic liver disease because it has a first pass to the liver. Functional ovarian cyst. When we have functional ovarian cyst, so the Clomid will enlarge this cyst. History of visual disturbance. Side effect of clomiphene citrate. First of all is the anti-estrogenic effect of it. As we said previously, clomiphene citrate has both estrogenic and anti-estrogenic effect. Anti-estrogenic effects act on the endometrium and cervix, so it will cause less receptive of the endometrium to the embryo implantation and less receptive of the cervix to the sperm. Second side effect is cumulative effect. What we mean by cumulative effects? Clomid, when we give a Clomid in this cycle, it will act for about how many cycles? About 2 to 3 cycles. So in the second cycle, when we give another Clomid, there will be extra dose of Clomid action, and third cycle and fourth cycle and so on. Risk of ovarian cancer. It's very rare, especially when we are use it for a long period of time, more than 12 cycles. Multiple pregnancy, especially twin pregnancy, in about 10%. Ovarian hyperstimulation syndrome is rare with the Clomid, less than 1%. Hot flash and nausea. Visual disturbance. What about the dose of Clomid? The Clomid drugs is a tablet, oral drug, of about 50 mg each tablet. So we can use 1 to 3 tablets per day. That's mean 50 to 150 mg per day. 1 to 3 tablets. Start from the cycle day 2 or 3 for 5 days. Maximum 5 days per cycle. About 95% of those who conceive on Clomid are conceived within the first 6 months of therapy. So we use the Clomid treatment for a maximum of 6 months, not more, because no benefit of using Clomid more than 6 months. Maximum conception occur in the first 6 months of treatment. 30% of women with the Clomid fail to ovulate by serial ultrasound. That's mean when we give Clomid in the cycle day 2 and then the patient comes in the cycle day 13, we will see by ultrasound there is mature follicle, and then after 2 days we see the same mature follicle and then get luteinization without rupture of the follicle. The follicle not ovulate in 30% of the patients. So we used pregnil or HCG for induction of ovulation in those patients. And this is given to trigger the ovulation when there is 1 to 3 follicles more than 18 millimeter in diameter. That's mean mature follicle. Mature follicle is follicle more than 18 and more millimeter. In polycystic ovarian syndrome women, those women can respond to low dose of Clomid, even half of a tablet, 25 milligram Clomid. We can give to them and respond adequately. The result of Clomid treatment, about 70% induce ovulation. There will be follicle and ovulation, while the pregnancy rate is just 20%. This discrepancy between the pregnancy rate and ovulation. Why? Because of peripheral anti-estrogenic action of the drug, as we said previously. There is anti-estrogenic action of Clomid at the level of the endometrium and cervical mucus. And also, the Clomid decreases uterine blood flow. All of those cause a low pregnancy rate with Clomid in spite of ovulation, because decrease in the endometrial receptivity and decrease in the implantation rate. As we said, 70% of Clomid treatment there will be ovulation, normal ovulation. What about the other 30%? 30% are not responding. We said to them, call them Clomid resistant women. Why Clomid resistant women? Due to three causes, either because of obese women, so that the dose is very little to her, or to start with, there is low estrogen level from the beginning. When there is low estrogen level, the Clomid action will be negative. Or there is large ovaries, like in polycystic ovary syndrome, a very large ovaries will be resistant to Clomid treatment. Second drug is Tamoxifen. This is also oral anti-estrogenic drug. It is very similar to Glomfin citrate in structure. Each tablet of Tamoxifen contains 20 milligrams. Glomfin citrate and Tamoxifen are equally effective in inducing ovulation. The dose of Tamoxifen is 20 to 40 milligrams, also started from cycle day 2 or 3 for maximum of 5 days. Third drug is Aromatase Inhibitor. It's also oral tablet drug. Aromatase enzyme is very important in the conversion of androgen to estrogen in granulosa cell. In the ovary and in the follicle, there is a granulosa cell. These granulosa cells contain aromatase enzyme, which convert androgen to estrogen, and the estrogen will secrete it in the blood and causes negative feedback effect on the hypothalamus and pituitary to decrease FSH-LH. In aromatase inhibitor, this action will block. So there will be no estrogen secretion, a very little amount of estrogen. When there is no estrogen, there will be no negative feedback on the hypothalamus pituitary. And the hypothalamus starts to secrete a huge amount of gonadotrophin releasing hormone, will act on the pituitary gland and will release both FSH and LH. Releasing of FSH and LH act on the ovary and causes folliculogenesis. The commonly used are two drugs, anastrozole and letrozole. Letrozole هو الفيمارة. Letrozole tablet 2.5 milligram each tablet. This is administered orally without any anti-estrogenic effect on the endometrium and cervix that is found with Glomfin citrate. This is the benefit of letrozole over the Glomfin citrate. It has no anti-estrogen effect on the endometrium and cervix because there is no block of estrogen receptor in the endometrium and cervix, like the Clomid done. The recommended dose is 1 to 3 tablets every day from cycle day 2 for 5 days. The indication is same as Glomfin citrate. Maximum estrogen suppression is achieved within 2 to 3 days of treatment with letrozole. Fourth drug is gonadotrophins. Gonadotrophins is injectable drugs. Indication of gonadotrophin injection as ovulation induction. It is first-line treatment in hypergonadotrophic hypogonadism. Why? Because no gonadotrophin. WHO class 1, as we talked about it in the previous lecture, they have no FSH and LH, 0 level. So the treatment of choice is gonadotrophin injection. Second indication is the Glomfin citrate resistant patients. The 30% of Clomid treatments who are Clomid resistant, second line of them is gonadotrophin. Third indication, fail to conceive on Clomid after 6 ovulatory cycles. We give the patient Clomid, and for 6 months or cycles, there will be folliculogenesis and ovulation, but no pregnancy. Then we change to gonadotrophins. Last indication is in vitro fertilization. We use injectable treatment. Why? Because we need 3 and more follicles. The commonest gonadotrophin preparation are human menopausal gonadotrophin. Menopausal gonadotrophin extracted from the urine of menopause, like Humagon, Minigon, Marional, and Bergonal. Human menopausal gonadotrophin injection has 1 to 1 ratio of FSH and LH, has 75 international unit FSH and 75 international unit LH. Purified HMG like Menopur, purified mean no protein with the injection, so less sensitivity will be occur. Purified FSH like Metrodine. This injection contains only FSH, about 75 international LH, with about just 1% LH. It's IM injection. Highly purified FSH, like highly purified Metrodine, which contain 75 international unit FSH and less than 0.1 international unit LH. So this can be given subcutaneously because it's highly purified and contain a little amount of protein. So it will be no hypersensitivity reaction to the drug. Commonest drug used in infertility are recombinant FSH, not a human being injection. The previous 4 are human being, extracted from the human being. Now this is recombinant FSH, synthetic FSH, like Puregon and Gonal F. Last drug is Urinary Hcg. Urinary Hcg used for a trigger of ovulation. We have 5,000 international unit or 10,000 international unit vials. Maximum dose of gonadotrophin for treatment of anovulation is 225 international units per day. That's mean 3 injections per day. Maximum duration of treatment is 1 year. Pregnancy rate is about 50 to 75%, which is much more than Glomfin citrate. When endogenous LH is elevated, FSH alone is better treatment, as in polycystic ovary syndrome. Polycystic ovary syndrome give them only FSH treatment without LH. Side effects of gonadotrophin. Common side effect is multiple pregnancy, which is about 34%. Second side effect is ovarian hyperstimulation syndrome. The mild form is more than 5%, severe form is about 1%. So because of those Side effects. The women with gonadotrophin treatment required monitoring. How we monitor women with gonadotrophin treatment? First of all, by serial ultrasound. Second, by evaluation of serum estradiol level. If by ultrasound there is more than 3 mature follicle, plus minus high estradiol level, we should stop HCG injection and ask the couple to avoid sexual intercourse because the risk of both multiple pregnancy and ovarian hyperstimulation syndrome. 5th drug is GnRH hormone, gonadotrophin releasing hormone. This is hypothalamic hormone, the first hormone in the reproductive system. This is used for hypogonadotrophic and ovulation due to hypothalamic dysfunction with intact pituitary gland. Gonadotrophin releasing hormone is the treatment of choice in this group of patients due to hypothalamic disorder. How we give it? We must give it in a pulsatile manner, like the natural or endogenous gonadotrophin releasing hormone. Naturally, gonadotrophin releasing hormone secreted from the hypothalamus in a pulsatile manner, not continuous. Also, the gonadotrophin from the pituitary gland secreted in a pulsatile manner. So, we use a computerized mini pump. It releases 10 to 25 micrograms subcutaneously or 5 microgram IV per each pulse. The pulses every 60 to 90 minutes, every 1 hour or 1.5 hours. The pregnancy rate is high, about 75% in this group. Ovulation in specific cases, like according to body mass index, the normal body mass index is from 19 to 30. Low body mass index, 18 and less. We use GnRH or gonadotrophin treatments because those with anorexia nervosa and very low body weight, they have less gonadotrophin secretion and less GnRH secretion. So the treatment of choice to them are either gonadotrophin releasing hormones or gonadotrophin injection. In obese women, more than 30 body mass index, reducing the weight is only the treatment, may be effective, very effective for induce of ovulation. In case of hypothyroidism, treatment with thyroxine plus minus bromocriptine. In case of hyperprolactinemia as a cause of anovulation, all of them are causes of anovulation. Hyperprolactinemia treated by dopaminergic agonist like either bromocriptine, parlodine الاسم التجاري. It is not ovulation inducer, but decrease the level of prolactin and will cause pituitary gland to be act normally. The dose of parlodine is 7.5 mg per day for at least 12 months. Cabergoline is the second drug in a dose of 0.25 to 1 mg twice weekly. Cabergoline causes no GI tract disturbance that's seen in parlodine treatment. So it's better to be used, cabergoline. If there is pituitary adenoma, like prolactinoma, surgical management may be required. In case of hyperandrogenism, we use dexamethasone, start from the cycle day 1 for about 10 to 11 days. This treatment is usually used in polycystic ovarian syndrome, which show sign of virilization, like hirsutism, harsh voice, and acne signs. Also can be used in congenital adrenal hyperplasia, whether primary or secondary, because of hyperandrogenism. Surgery. We can use surgery like laparoscopic ovarian drilling for polycystic ovary syndrome. This surgery takes a risk of anesthesia, so it's only appropriate in women who are resistant to clomiphene citrate treatment. What about the class 3? We talked about class 1 and class 2 anovulation. Now what about the class 3 anovulation, which is hypergonadotrophic hypogonadism? This type of patient, usually because of premature ovarian failure, they have arrested folliculogenesis in the age of 40 and less, associated with high level of FSH and LH and low level of estrogen, like a menopausal woman. Spontaneous ovulation in this group of patients, successful pregnancy can be only occur in 5 to 10%. There is no treatment for this group of patients. No role for clomiphene citrate, no role for gonadotrophin treatment, and even for gonadotrophin releasing hormone agonist treatment. Egg donation or adoption may be the only options for this group of women. We finished ovulation induction. We finished treatment of anovulation. Now the second cause of female infertility is the tubal factor. So what about the treatment of tubal disease? First of all, surgery. The treatment of tubal disease aims to restore normal anatomy of the tube. Chance of success depend on the severity of the damage and the location of the damage in the tube, as well as the skill of the surgeon. For peritubal adhesion, can be removed by laparoscopic adhesiolasis. For fimbrial adhesion and blockage, this can be corrected by surgery called fimbrioplasty to open the fimbrial blockage by laparoscope. This surgery increases the risk of ectopic pregnancy. Tubal surgery increases the risk of ectopic pregnancy in the future. Second option for tubal management is in vitro fertilization, أطفال الأنابيب. If there is severe tubal damage that is not repairable, or if the surgery failed to restore patency, we did surgery to the tube and it is failed to restore the normal anatomy and action of the tube. So the treatment of those group is in vitro fertilization, IVF. In this group, if there is hydrosalpinx means blocked tube and swelling of the tube with the accumulation of fluid inside the tube. If this is present, it's advisable to remove it by salpingectomy. Remove the diseased tube before IVF. Why? Because it is affect the success rate of the IVF. Decrease the pregnancy rate after IVF. So we must remove the hydrosalpinx before IVF treatment. Third management is the management of uterine causes. Ascerement syndrome. Ascerement syndrome is adhesion inside the uterine cavity. We can remove the adhesion by hysteroscope. This is the hysteroscope. A scopic surgery enter inside the uterine cavity for both diagnosis and therapeutic. If we see adhesion, like in Ascerment syndrome, we can remove the adhesion. If there is submucous myoma, also we can remove it either by hysteroscope or by laparoscope. Any uterine anomalies like uterine septum can be removed by hysteroscope also. What about the male subfertility? Management of male subfertility. In case of hypogonadotrophic hypogonadism, when there is no gonadotrophin secretion from the pituitary gland, the causes of hypogonadism are either hypothalamic or pituitary dysfunction, so the treatment of choice is gonadotrophin and HCG to restore spermatogenesis. In case of idiopathic oligospermia, gonadotrophin therapy is ineffective, so intrauterine insemination or IVF may be the appropriate treatment for this group of patients. In case of idiopathic oligospermia, either we do intrauterine insemination if the seminal fluid parameter is a little bit good, or IVF if the seminal fluid analysis parameters are very bad. In case of obstructive azoospermia, can be offered sperm aspiration and followed by IVF. We aspirate the sperm from the epididymis and then go for IVF. In case of testicular azoospermia, azoospermia means no sperm in the ejaculate, and the cause is testicular. So we do testicular biopsy and then do intracytoplasmic sperm injection, ICSI. 25% of men with abnormal seminal fluid analysis have varicocele. There is no evidence that surgical ligation of varicocele can improve pregnancy rates. Antioxidants like vitamin C, vitamin E, and glutathione can improve seminal fluid analysis parameters, but in the absence of data till now for definitive outcome on the pregnancy rate. Glomfin citrate, androgens, and bromocriptine are of no benefit on semen parameters. Next lecture will be assisted reproductive technique. Thank you so much for your listening.